So this is palliative care for finals. Again, quite a long one, and not the happiest, but try and think of palliative care as like how to make dying nice, if that works for you. So it's mostly about like symptomatic management of things that in other patients you would just find a way to cure it or like mitigate it as best you can. But in palliative patients, these things are happening, and you're basically saying these patients are going to die at some point soon. So whatever we do, we just need to make it as comfortable with them as we can. So like generally like drug dosages and stuff like that, you tend to give them much bigger doses than you would say someone like us guys. So I've not gone into dosages on this, but generally like if you're looking at these things thinking, okay, how much morphine would I give, etc., it's usually a lot higher because you're not as worried about like the negative side effects, or you're wanting to like overdose in a nice way, if that makes sense, because these people tend to be in a lot of pain and distress. Cool. So first off, we're going to treat this session as though it's like an interactive one. You guys are baby junior doctors and it's your first day doing, you've got a week on palliative care in the middle of a rotation, and you've been thrown in at the deep end in a hospice or in a palliative ward. And these are the kind of jobs you might expect to have coming at you, the kind of patients you might expect to see, and the things that they might have going on with them. So obviously, biggest complaint that we get from a lot of patients in palliative care is generally that they've got some kind of pain. Kind of include a little image of your pain side there, just to kind of remind you that whenever you're looking into pain and stuff like that, don't forget to ask like your Socrates, like severity, etc., etc. But regardless of the severity and the underlying cause, there are certain things that we can do to make the patient feel more comfortable and get rid of it, because in the end of life, patients, when they're experiencing pain, it doesn't just tend to be one specific cause. It can be lots of different kind of pains altogether, and we want to just like hit it with the strong stuff and make them as comfortable as we can. So pain is what we consider to be an unpleasant sensory or an emotional response to what you call noxious or unpleasant stimuli. So that can be a mixture of things such as drugs that you've got them on causing side effects, pressure sores because they're sitting around in bed all day, acute pain from like the underlying pathology that they've got going on, or even spiritual and emotional pain, because I think I've got an image of the pain pathways if you've got the handout, which I should have posted on the event, or it should be on the Antiemetics page soon. I've not got it in the slides, but if you look at like your pain pathway and stuff, there's various parts of the brain where you'll know sort of like psychosomatically you can kind of pain can manifest, and very much if you give a patient a therapeutic management for it, it somehow kind of works even though that's not the underlying mechanism. But always worth remembering that spiritual and emotional things, particularly in this group of patients, are like really key, and you don't want to forget about kind of exploring that side of things. But generally, the main thing that we're going to treat pain with in palliative patients is opioids, the stuff that like really does the job. And you would term a patient that hasn't been started on opioids yet or isn't regularly taking them every day as opioid naive, whereas someone, for instance, who is regularly on opioids is opioid tolerant. So normally we're just going to start with a short-acting opioid, so that could be Oromorph or oral morphine, if they are like tolerant of the oral route, or subcutaneous if they're not tolerant. And if they're going to start taking that quite regularly, as most patients who are palliated do, you then need to work out the 24-hour dose. So how many times they need in this in 24 hours, and then you possibly need to like consider converting over to a syringe driver if you want in a consistent infusion, so that you're not having to like constantly go and like top up the medications and stuff. And then you also work out something called the breakthrough pain. So like how much breakthrough morphine do you need to prescribe, and write that up separately. So like the way that we're supposed to target pain, even though we talk about going straight in with opioids in palliative care, is you use your WHO pain ladder. So you'll have seen this outside of palliative care as well, but it was generally like drafted up with cancer patients in mind. Obviously not all patients who are palliative are cancer, but generally like the majority of them are. So that's why sometimes it's also called the cancer pain ladder. So you start on non-opioids. So you're thinking stuff like paracetamol or non-steroidal anti-inflammatories, and then adjuvants. So adjuvants can be anything else. So the non-opioid that you didn't use, or like neuropathic painkillers like pregabalin or tricyclics, things like that. And then as the pain persists, you're going to keep going up. So then you start to add your opioids in, and then you can also mess around with your different types of opioid as well. So like I've described it a little bit just on the left there. So ideally pain relief in palliative care should be by the clock. So it should be available to your patient 24 hours a day and PRN if they want it. Should be by the mouth where they can, just to kind of maintain that sense of normality, unless they don't have like they're swollen and stuff like that. And by the ladder. So you should be obeying the rules of the WHO pain ladder. So start with paracetamol, then consider stronger things like codeine and ibuprofen, and then you'd work up to morphine or other types of opioid, like, because we're about to talk about in a second, there is like a hierarchy of strengths with your opioids. So your opioids, yeah, these are the main kind of state of drugs you'll use in palliative care. I don't know if you'll have done about palliative prescribing, if any of you have been to Jenna's sessions that she's been doing, but I'm not going to talk much about like how you write things up and what you look into, because again, that's like a whole session in itself that I could do or someone else could do another time with you. But generally with opioids, you're normally going to start with morphine, diamorphine or morphine in its various forms, and you'd find the various forms within the BNF. If you've got a patient who's in renal impairment, you would probably use fentanyl, which is usually available in patches. And oxycodone is a good one to use if you've got patients that are really struggling with the side effects of morphine. So this is some of the side effects of morphine in this picture here. So like your common ones are, they're really constipating. Patients tend to get like very easily nauseated and dry mouth. Everything else is like a little bit rarer. And obviously respiratory depression is like your real worry and overdose. And like it tends to go on a scale of like those minor side effects to when they're in severe overdose, it can lead to like myoclonus, confusion, respiratory depression. And that's kind of when you want to start looking at getting naloxone out and stuff like that. And I've included a little list at the top there of the potencies of the different types of opioids. So you can just, if you're ever struck and you're thinking, is that stronger than that? You can just kind of refer back to that. So when you're converting opioids, let's say you've decided, right, I want to switch them over to fentanyl from morphine because this patient now has a renal problem. You need to work out what your total dose of the morphine is in 24 hours and divide that by the potency of the new opioid to get the new dose of the opioid that you need in 24 hours. You're going to look up a preparation of that in the BNF. So like, what is the tablet potency? How many daily doses am I giving? And then you're going to look in the BNF for forms of that medication. So is it patches? Is it oral? Is it subcut? Things like that. And then you need to make sure that you're prescribing breakthrough analgesia. So you need to have this backup PRN medication that you can prescribe sort of like 2 to 4 hourly as and when the patient needs it. And you work it out as being a sixth of the overall, well, they say about a sixth to a tenth of the overall dose of 24 hourly opioid that the patient is on. And you should review it every 24 hours as well, because obviously if the patient is needing to use that breakthrough pain killer quite a lot, you need to consider incorporating it into the next day's dosage of opioid. And generally, like, these dosages can get very, very high because patients have a lot of pain and they are using them. So yeah, is that. So again, like, I'm not going to spend ages on this, but this is more for when you're practicing prescribing opioids, just to remind you where to look. So it's under the medicines guidance and prescribing in palliative care. You've got a whole load of things, actually, like I've used a little bit when I've been making this presentation, and you'll use it when you're doing your prescribing. It's got like information on a lot of drugs that you'll give in certain situations in palliative care, and it's got all of your conversion charts as well. So you can like vaguely remember sometimes, like, okay, that's half of that, that's roughly that. But also, like, if you're like me and you have the memory of a goldfish, you might as well just know where to look it up and use the charts. Yeah. And then the same applies for like equivalents of like morphine to fentanyl and different things like that as well. When we talk about adjuvant analgesia, that's like any painkiller that you're giving as a assistant with your opioid or like your non-opioid, wherever you are in the ladder. So usually when we're talking about opioids, you're going to give paracetamol because it's the easiest and most available one to give. But there's different ones that can be indicated in different types of pain because they've got a more specific mechanism. So examples include, if you're looking at someone who's got colicky pain, you're going to look to use something that's got antimuscarinic properties. So like isobutyl bromide, also better known as Buscopan, If it's cancer-related bony pain, think bisphosphonates, because there's usually like hypercalcemia as the mechanism there. Skeletal muscle pain, you can use relaxants like baclofen. Neuropathic pain, you want to be thinking pregabalin or gabapentin, and amitriptyline has properties in that kind of area as well. Inflammations, NSAIDs, but also always covered with gastroprotection, such as like omeprazole is probably your most common one. Whereas like cancer-related pains and edema, corticosteroids, so dexamethasone is usually the best one for that. Generally, if you're thinking any kind of terminal event that is somehow related to cancer and obstruction, dexamethasone is quite a good tick drug to have in your mind. Patients who are frequently having seizures, keep them on antiepileptics. It could be that they were epileptic before, it could be that they've got brain metastases and they're getting seizures that are new, but you still need to manage them as well. And also like some antidepressants have properties in affecting descending pain modulation. So they can be useful where the cause of your pain isn't entirely known. So yeah, and you don't have to worry quite so much about when you're starting a patient who's terminal on antidepressants, those like, obviously you're going to monitor it, but you're not per se expecting them to be on it as long as someone else like our age, for instance, might be. Cool. So next little scenario for you, you are doing your ward round and you come across a patient who has been struggling to tolerate their oral medications, and you're not entirely sure why. So you're going to investigate the underlying cause of this. So you're potentially thinking, my patient isn't going to be able to tolerate oral medication. This is a really big deal because this patient at the minute is dependent on me being able to give them morphine, haloperidol, whatever it is to manage their symptoms. So you want to go by the parenteral route. Now the parenteral route for feeding is different to for giving drugs. Obviously you're not going to give food subcut, but we tend to start giving injections, start using syringe drivers which go in via the subcut route when we're switching patients from oral to who can't tolerate it anymore. So syringe drivers are those little things. If you've done palliative care, you will have seen them. If you've not, they're quite rare to just like see around in public, but they are quite easy for patients to like carry on them and stuff. And they're those little, you can see the little box there in the bottom right. And basically they can just contain a big mixture of drugs. They're given subcut. Patients have the medications themselves, so they're trained in how to use it and they can sort it out. And they generally replace the medication, say about once, like, well, it depends however long the infusion is, but it could be once every day, once every couple of hours. And you're going to give them, if your patient has problems with nausea and vomiting and they don't want to tolerate oral medication anymore, swallowing problems, they're really weak, they're in a coma, or they've got bowel obstruction and they just wouldn't be able to absorb the oral medication. But there can be problems with the infusion being too slow or too quick, and therefore just not either covering their symptoms enough or not lasting long enough. And injection site reactions are quite common as well. So that could just be from having, like, not a side effect of the medication itself, but just from having something uncomfortable sitting in the skin, or it could be like a drug irritation reaction. And obviously you can still get all the same kind of overdoses that you could get with medication, say morphine and like respiratory arrest again. You can use most drugs that you can give orally or in solution in a syringe driver. And there's sometimes people say that, oh, there's issues because cyclozine crystallizes and this one does this, but generally like not really worth worrying about at our level. Drugs that you wouldn't give because they can cause really bad skin reactions, so they're contraindicated, are two antihistamines, aren't they? So I can never say these two, chlorpromazine and prochlorperazine and diazepam. You might not consider giving cyclozine and levomethomazine in a syringe driver, but it's not totally contraindicated. And normally you will dissolve these in either water or saline just to help them infuse a little bit easier as well. Cool. So next scenario, you've got a patient who is complaining that they're struggling to catch their breath. So it could just be that they've been running laps up and down the ward, or it could be something else that's going on. So again, dyspnea is something, or breathlessness, something that is quite common as we get older, but generally it's usually secondary to something else that's going on in a palliative patient. So it could be that they're really anxious and they're just hyperventilating. So it's then worth like kind of exploring the emotional side of it with relaxation techniques, breathing techniques, things like that. It could be that pain is making them hyperventilate. It could be that they've got reduced respiratory function, say if they've got pulmonary fibrosis as their palliative condition, something like that. Pulmonary edema from heart failure, or just from like secondary to a tumour, something like that. Yeah. Or infection, again, because they're immunocompromised for some reason, or anemia. Anyone who was in my anemia session last week, anemia of chronic disease, or like anemia is caused by hematological and like metastatic causes, are kind of common with this group of people as well. So again, you want to think about non-pharmacological interventions first. Can you relax them? Does helping sit them upright instead of having them led back make a difference? Do you want to consider pulmonary rehabilitation if it is something to do with their respiratory function? Could you just put them on oxygen, whether that's nasal specs or like CPAP or whatever? Will nebulizers help? So it could just be like nebulized saline. It could be nebulized salbutamol, just to open their airways a little bit. And morphine as well. I think it works just by kind of tackling the anxiety a bit, obviously because it depresses the respiratory center a bit. It's not so much that it's opening the airways or anything like that, but generally you tend to find when you treat patients who are in pain with quite a lot of morphine, they then aren't complaining of breathlessness, so it can have kind of a dual help there. But if you are prescribing it specifically for breathlessness, you've got to make sure on your prescription chart that you are writing in separately to any other morphine they're prescribed for pain, and you're putting that in your indication box as well. So other drugs you can use, again, it's just like going back to the cause. So if it's edema, consider a diuretic like furosemide. If it's anxiety, consider a benzodiazepam such as diazepam. If it's, again, tumour obstruction related, consider like corticosteroids like dexamethasone. And if it's anemia, you want to consider iron supplementation, looking for the underlying cause, or possibly giving a transfusion, for particularly if they've got like hemoglobin below about 80 or 70. So you go to see another patient, you look inside their mouth and it looks like this, which I think everyone can agree, pretty horrible. If you know what you're looking at, that is oral candidiasis. So dry mouth, again, pretty common amongst these patients because they can't keep themselves very well hydrated. A lot of them are immunocompromised because they're on steroids or chemotherapy. So they're more prone to infections, and they're on a lot of drugs like opioids can give you a dry mouth, antimuscarinics particularly, that's a well-known side effect of them, and antidepressants as well. So you've got to consider various things such as their hydration status, and what like the underlying drugs are that are going on, or is it a candida infection? So depending on what the cause is, make sure they're getting good mouth care, and you're hydrating them well if this is particularly an issue. Like, had you maybe not noticed this patient all of a sudden isn't getting up and drinking, because it can happen quite quickly. There's different things you can do that can stimulate saliva production. So sucking ice and chewing gums, one of them. Artificial saliva is available, which I remember seeing when I was on palliative care and being like, that's a bit gross, but it makes sense. Because a lot of these patients, if they're on antimuscarinics, they can't just stop taking that for their other symptoms, but they want to kind of feel some sense of normality. And then if you've got candidiasis going on, you can treat that with oral nystatin or oral meconazole or fluconazole, one of your azoles, your antivirals. So then in a similar kind of vein of symptom, you get dysphagia or struggling to swallow. So this could be mechanical, it could be because your patient is weak and struggling to swallow. It could be that there's a tumour that's obstructing the area, or it could be that the dry mouth that they're experiencing actually is the underlying cause, in which case refer to the above and treat that way. So ways of managing it: if it's dysphagia that you just can't overcome, obviously consider switching to the parenteral route, both for feeds and for medication. If it's obstruction, again, consider a steroid like dexamethasone. If they've got muscle spasm, you could use something like baclofen, but that might be a little bit too like high grade. So you could just consider GTN spray to relax the muscles there. And in patients who are like cancer patients who are palliative, that have like the time to be able to go down a surgical route, you could consider esophageal stenting if it's obstruction that's causing their dysphagia. And for patients who are producing excessive saliva, you could treat them with an antimuscarinic like hyoscine hydrobromide. So whereas a lot of patients tend to get dry mouth, it is also possible for it to go the other way too. Cool. So you're then told to go and see a patient who's not been feeding very well. Again, very common thing as we get older, appetite does reduce. But usually like this is exacerbated in patients who have what you call anorexigenic factors going on as well. So it could be that they have got dysphagia and therefore they're not eating. They're anxious, which is suppressing their appetite. The pain is making them forget to want to eat. They've got GI distension, ascites, nausea or constipation, or it could be a side effect of medication, like the nausea or the constipation, for instance. So again, with this, always treat the underlying cause. If you've got a patient who, for whatever reason, just really doesn't want to eat, and you're still like, you know, they're starting to like rapidly lose weight, and you're thinking, okay, we could prolong this a bit more. They're not. This doesn't have to be what kills them. Consider giving dexamethasone to stimulate appetite, because that can work quite effectively. And make sure dietitians are involved as well, because it could be a silly little thing like they're not tolerating the solid food, so they need to switch to a supplement or something. And then parenteral feeding. And because I always used to get very confused with the types, I put an image in here just of the different, like what's TPN, what's a nasogastric tube, where do they go in. So these slides, again, like they will be available on the Antiemetics page. So if you're wanting to refer back to that as a handy guide, like that's there for you. So different types of gastric pain, again, this can be like one of your key causes of patients not wanting to eat or feeling uncomfortable. And even though it's pain, not always the best idea just to throw loads of morphine at these people, because there's something else that's going on. So it could just be a simple bit of dyspepsia or acid reflux, in which case just treat as you would any patient, suppress the acid reflux with proton pump inhibitor or a H2 receptor antagonist. You're going to use the PPI first line where you can, just because they tend to just work a little bit better. If they've got bowel colic, I think we mentioned this one before, give them an antimuscarinic. So any of the hyoscines or glycopyrronium. Gastric distension is usually just like a little bit of what's the word? They're not digesting things very well, so consider antacids or prokinetics, which is domperidone, just like keep things moving. A little like pro-motility medication, just to keep things moving a bit more. And if they've got hiccups as well, this is quite a common thing in palliative patients, that they get hiccups and there's nothing they can do about it. So you meet these patients that just hiccup in. A lot of them find it quite funny, some of them find it quite distressing, but it generally is just due to like chronic gastric distension, which is then irritating the diaphragm. So you can try and treat it the same way as you would gastric distension, but you can also consider metoclopramide, consider muscle relaxants like baclofen, calcium channel blockers like nifedipine. And don't forget that constipation and diarrhea can be causes of this as well, but I've given them their own space because I just thought they needed a little bit more talking about. So cool. That's a nice Bristol stool chart for you to enjoy in this one. So make sure, if you've got a patient who's got diarrhea, first things first, review the diet and the medication. Is it being caused by something you're giving them? For instance, is it that they've had constipation and they're now like they've gone the other way? And I guess, yeah, Bristol stool chart there, because again, always assess when it comes to constipation and diarrhea, like assess exactly what it is, because it can tell you a lot about whether it's like sort of an infectious cause, is it a fecal impaction kind of cause, is it dietary? If it's really bad diarrhea, make sure you're giving them oral rehydration therapy, because otherwise you can give rise to all these electrolyte abnormalities that can cause a whole host of problems. And your main way of treating it is with loperamide, morphine, because obviously that can, one of its main side effects is it's constipating, and octreotide is this somatostatin analog, which is really good in quite a lot of like niche things in palliative care. So in this instance, it's quite good in diarrhea that's happening secondary to cancer treatment. Also, don't forget that it could be that your patient's got a bit of a weird and wonderful infection. So do they have C. difficile? Do you need to treat that, for instance? And yeah, don't forget that just because it's constipation doesn't mean that it can't be fecal impaction that's masking diarrhea instead, because a lot of these patients, like with any old person on the bed in hospital, they aren't moving about much. They can't go and clear the bowels very much. So it can unfortunately be like a bit of a mixed case of the two. So on to constipation. So yeah, again, just with the fact that a lot of these patients aren't getting a good diet, they're prescribed a lot of medications that are constipating, and they're not moving about much. Constipation does tend to be a lot more common than diarrhea does. So you need to consider all those factors in like making sure that they're getting like good fluid dietary intake, quite a lot of fibre. Consider when you prescribe an opiate, consider co-prescribing a laxative. So I think you prefer to use the stimulant ones, but I will check. So I've got that down there for you. Yeah, so you'd usually use a stimulant with an opioid where you can, so like Senna or Dantron or something like that. And there's lots of different types. I'll try and like briefly talk about like what they're used for, but generally like there's quite a lot of crossover because there's a lot of similarity in what they actually do. So your stimulant laxatives, obviously they're going to stimulate peristalsis of the bowel to make the patient want to go. Generally, like they take a few hours and then they're pretty good to go, quite smooth. But you don't want to give them intestinal obstruction because you can make the intestinal obstruction worse. Osmotic laxatives, they tend to be like really sugary because that's how they work. They're big polysaccharides that they're undigestible, so they start to pull the water into the bowel, stop you making these like hard stools that are really difficult to pass. But you want to be careful with them in patients that are diabetic because they're sugary, but they're quite good in chronic constipation where patients just, they're not producing good stools. With bulk forming laxatives, they sort of work well in patients that aren't getting good fibre intake because they do the same as what fibre would do. So make this kind of bulkier stool, which then affects the mechanoreceptors in the bowel, so the patient then wants to go. And similar kind of thing with your stool softeners, kind of a similar effect as well. They can have like some degree of bulk forming activity. So docusate sodium is an example of that. But they're also quite good where you've got perianal disease. So if you've got patients that have anal cancers, have hemorrhoids, things like that, it just makes it a lot more comfortable for them to be passing motions. You can also do rectal intervention, so suppositories. And as a last resort, you consider things like phosphate enemas and manual evacuation of the bowel if you really have to. But obviously that's quite like, ideally you'll have prevented that before then. So you now have a patient who isn't letting it loose down there, they're letting it loose this way. So you've got a queasy, vomiting patient. What do you do? So antiemetics are another wonderful one where you've got a whole host of different mechanisms going on, and the drugs that we, like the different drug classes that we prescribe, like obviously it's a lot more tailored, even say than the anti-constipation drugs are to the different underlying types. So if you, for instance, are prescribing cyclazine for something that's to do with gastric stasis, it's going to do absolutely nothing because that's nothing to do with the histamine receptors. So you've really got to kind of, the table that's in the top right is probably a bit too much. Like I only ever really learned it as like, this drug is a dopamine receptor antagonist or whatever. Like it's kind of hard to remember things that do 3 or 4 different activities, but if that works for you, go for it. But yeah, like with the basics of the kind of the vomiting nausea pathway, just remember that you've got your chemoreceptor trigger zone, the CTZ, that's like up here, medullary, like vomiting center, labyrinths in your ears. So that's kind of how when they're upset, motion sickness sort of kicks in, and then your GI tract, that kind of works through the vagus nerve. So I put just like a little summary here of like what affects what, but again, don't worry like too much about just committing it all to memory now, because I used to like really struggle remembering which drug worked for which. So yeah, different cause, like common causes in palliative care of nausea and vomiting, which is a very common symptom. It could be a side effect of opioids or other drugs. It could be the cancer treatment that they're on. It could be an anxiety related thing. Can come with hypercalcemia, uremia, or other electrolyte disturbances, bowel obstruction. It could be that they've got a tumor that's like, for instance, like releasing loads of serotonin, or it could be brain metastases. So quite a lot, that's the sign a patient has like brain mets, actually, when they all of a sudden start finding themselves really dizzy and they're vomiting quite a lot. It could be constipation that's kind of causing gastrointestinal upset, or it could be raising intracranial pressure. So if you can solve it without drugs, amazing. Try giving your patients smaller meals, put them in a calm environment that's like away from where food's being made or there's any obnoxious smells. Consider lying them down if they're feeling quite refluxy, or putting them in the right position and having things near them to vomit into. And consider like parenteral feeds again, so that they're not having to like try and tolerate swallowing. Your main antiemetic that you're going to use in palliative care, if you're not like assessing the underlying cause, is cyclazine. It just tends to work the most for people. And then you add haloperidol in if symptoms persist. If it's a motion sickness related cause, antihistamine works well because you've got histamine receptors in the vestibular center. If it's gastric, consider giving metoclopramide. Again, that there's always like secondary drug studies and different guidelines. They're different in different places, but I'm doing this kind of based off multiple sources that I have that work together and what I learned. So that's not to say that other drugs in the same class don't work. It just tends to be what is recommended. Chemotherapy on danzatron works really well. And if it's metabolic, haloperidol works really well. The thing to remember with your D2 antagonists is, I think particularly with haloperidol, because it's an antipsychotic, they are contraindicated in Parkinson's, which obviously like there's a fair chance that quite a lot of your palliative patients might have. And yeah, you want to watch out for that, watch out for extrapyramidal side effects. Was there anything else? Yeah, that was about it with them, I think. And where on danzatron is concerned, there's a side effect I thought was quite important with that. It's another constipating drug. That was all I've got down for that. Where you've got resistant cases, you can use levomepromazine, because as we saw in the last slide, that's the one that has like good coverage against like all of the different receptors. So we tend to reserve that for more a bit like, don't really know what's going on here, nothing else has worked. If you're having issues with getting, like, despite what treatment you're giving the patient, the amount of vomit that they're experiencing is just generally like causing them anxiety, consider giving them octreotide, because that's shown to reduce the amount of vomit. So that's, again, this is the somatostatin analog that we saw before when we were talking about secretions. If the cause is raised intracranial pressure or bowel obstruction or lack of appetite, consider giving dexamethasone. Okay, this one, yeah, quite a sad one. I think always one of the worst things you can see in patients who are palliative, because very often when you do see them on the ward, they are usually on quite a cocktail of drugs and they're pretty chilled out. It's when you get the anxious patients, and often, unfortunately, you get patients that are particularly young and they're feeling like extremely unsettled because they're not ready to die yet, or they've got some symptom going on that they're not prepared for it. They don't know how to handle it. Luckily, there is something that we can do about it. So yeah, obviously in older people anyway, you're in a weird, confusing environment. They are very disorientated and delirium is not uncommon. And you term this as like delirium or terminal agitation. So either way, I mean, this is generally is like more the general management for delirium anyway. You want to keep your patient in a well-lit room. You want to make sure that they're seeing consistent people, that you're giving them like explanations when you see them and not trying to be confrontational with them. And use one-to-one nursing where you can, because sometimes they can be a bit like, whoa, okay, loads of people scared. And then they're a risk to themselves as well, because I don't know if anyone's ever seen delirious patients before, where they sort of come into the angry side of it. They can be quite combative, and yeah, then they're at risk of hurting themselves and stuff because they're not really aware of the situation and that they need to stay in their beds and things like that. So for patients who are suffering from terminal agitation, so generally ones who have awareness of what's going on but they're really anxious, midazolam and benzodiazepines work really well. For patients experiencing delirium, hallucinations, whatever else it is, haloperidol works quite well because of the antipsychotic properties it's got. And you can consider using, again, levomepromazine. If you're stuck, that's the drug to go to. It seems to be in palliative care, where if you tried everything else, it just seems to work. If you've got patients who are just generally anxious, it might not be that they are terminal, because obviously, again, palliative care isn't just about terminal patients. It's not about people who are just about to die. Then you can consider benzos as well, and they work quite well for insomnia too. And it could just be that they've got a cerebral tumour that's causing a bit of a mood change, so do consider that, and again, consider dexamethasone. Cool. So some of your colleagues are raising concerns with you about a patient who's got quite rattly breathing. It's not so much they're struggling to breathe, they're just really loud when they walk past on the ward. So what do you want to consider doing? So you get this thing called terminal secretions, and not to overuse the word terminal, but I guess that is what we're talking about. You basically just start to produce more secretions towards the end of life, and it's just from a mixture of, as with everything, like mechanisms breaking down, you're producing a bit too much, and your mechanisms for like your ciliary hair cell action isn't quite as as good as it is in use, or patients are lying down a lot, so they're not able to excoriate as well as they should be able to. So you tend to get patients that have this like very like, it's referred to as a death rattle sometimes. And it can sound quite scary, but there's ways of treating it. So you could consider giving, well, the first thing you'd want to consider giving is glycopyrronium, and you can either give that as a one-off dose, or you can consider shoving it in the syringe driver if this is a patient that's having this as a recurring thing. And also you can consider your hyoscine, either butylbromide or hydrobromide, but this can cause a bit of a secondary agitation, and again there's like the side effects of antimuscarinics to like consider with that as well. You don't want to make it worse by giving them a dry mouth. The good thing about kind of, again, it was like treating morphine for breathlessness and painkillers. They can have a good secondary effect of reducing bowel colic and any secondary nausea and vomiting as well. So in the right doses, they can be useful for a few different things. So your patient that had the death rattle, unfortunately, you're still pretty concerned about them. The glycopyrronium hasn't worked. And in fact, the breathing's starting to sound like a little bit mixed. Sometimes it's really fast. Sometimes it's quite deep and slow. So you think about diagnosing this patient as being in the last few days of life. So anyone that's done palliative care will know that when you talk about giving life expectancies to people, it's not really a thing that we can do. Like, you can only do it based off of data that we've got in about conditions and based on the look of the patient. So if the patient, the general rule that I got taught was like, if the patient is getting worse in days, they've got days to live. If the patient's getting worse in weeks, they've got weeks to live, etc., etc. But death has these sort of like end signs that you can kind of track, be aware of, and then think about putting things in place. So patients tend to get this erratic breathing, they lose their appetite quite rapidly, they're sleeping all the time, they might be quite confused and agitated, and they're generally quite withdrawn. So someone that's been chatty all their life and doing loads, even like up until a few days before dying, can just suddenly become very quiet and want to be left alone. And you tend to get this like reduced perfusion, so they might feel really cold and mottled, increased secretions, and then the breathing I was describing just then, where they get that mixture of like deep, slow with faster, shallow breathing, is called chain-stoked respiration. It's just a characteristic type of breathing that you don't always get, but you can get in people just before they die. So you want to consider, obviously, like, it's a big one to like counsel any family or attending people that they've got coming in and seeing them. And you want to produce an individual care and communication record, which is, if anyone was familiar with the Liverpool care pathway before that was a controversial thing and got abolished, that's what it's replaced with now. But just broadly, like, you want to make a plan with the patient if they are still compos mentis, and you can do that with them or with the relatives or with the carers, to kind of say, does this patient, have they got spiritual needs that they need attending to? Are there things that they wanted to do before they die? Would they rather die in the, like, if there's an option of moving them and they're in the hospice, for instance, would they rather die at home? Do they have a preferred place of death? Is everything in order for them? So like, this is only really possible in the patients who are having, like, I guess, a more prolonged death, and you can kind of see it coming a little bit, because obviously a lot of people do just tend to die quite suddenly. So something that you want to consider in these and any patients really that are in hospices that could be like coming in and out quite a lot, for instance, you want to do something called anticipatory prescribing. So this is where one of the few instances, like with giving COPD patients like preemptive rescue packs of antibiotics and stuff, one of the few instances where you write a prescription and you just trust the patient to kind of do it on their own, or like whoever their carer is and things like that. So these very often get dished out in the community. So it's a lot of PRN as and when medication that you're going to give to patients in their last few days of life. And like, the recommended drugs vary trust to trust. So I was reading up on this earlier. In Scotland, for instance, they pick levopromazine instead of cyclizine for agitation. So what I've written down here was based on what I learned when I was in St Helens and Nosey last year. So if some of you guys disagree with what's on here, that's fine. But I think it's more just like, know about what anticipatory prescribing is, I think is the key thing. So cyclizine generally was the recommended one that they wanted to give for, okay, that's another point as well. So you're not necessarily prescribing for the symptoms the patient has. It could also be that you're prescribing for symptoms you're expecting them to have. So therefore you would give them a tailored drug to what their underlying cause was if they had one that you knew of, but if not, you're just going to give them like the go-to first line thing. So it would be cyclizine for as your antiemetic, midazolam for anxiety, glycopyrronium for breathlessness and secretions, morphine for, again, breathlessness and pain. Yeah. A little like thing of interest that's not, it's more ethics based, that I remember covering a few times when I did palliative, was this thing called the double effect doctrine. And I don't remember if it was something that I learned specifically in the teaching that I had in the hospital I was in, or again it was something that potentially could come up as like a multi-choice question, okay, like what is this? But the double effect doctrine, it's just basically this like kind of defense, it's a legal defense mechanism or an ethical principle whereby you're wanting to do an act and you know that good can be brought about through it, but there's also most likely going to be a harmful effect there as well. But you can justify doing the bad thing so long as that occurs as a secondary consequence and it's not what you intended to happen. So it can't be that you achieve the good thing through the bad thing, and there can't be a safer way or a better way of doing it as well. So like the main example that we use this in ethics, I guess it doesn't really apply to palliative care, would be when you perform an abortion, which obviously could be perceived as a negative thing from the perspective of the fetus potentially, but continuing the pregnancy might be at risk to the life of the mother. So really like you're doing a good thing and there is a bad secondary effect, but there would be no other way of achieving that primary. Similar thing with euthanasia, like obviously death, the killing of a patient is never a good thing, but not that it's legal in this country anyway, but arguably like you're bringing about something good despite the fact it's going to have a negative consequence for the family and people around them, and it's putting the patient out of their pain. And in the palliative sense, just for example I thought of was it could be, say, administering morphine brings about pain relief for these patients, but in the dosages you're going to give it, it's also going to give a whole host of the side effects, and then you're introducing that risk of overdose and respiratory arrest. So yeah, it's just worth knowing what that principle is. Okay, so on the final stretch, so we have these things called palliative emergencies. There's a debatable number of them really, because quite a lot of what we've talked about, like who deems what an emergency, it depends how late it happens in a palliative patient's care. Obviously not all of these, if any of them are ever going to happen, but these are like the big ones I thought about that we haven't touched on at all. So like another one that I've not put in these slides that is probably malignant bowel obstruction, but I kind of thought the way you treat that basically is the same as you would surgically treat bowel obstruction anyway, and I'm going to assume you've probably covered that with Alex in his surgical teaching, or again it doesn't really fall in the remit specifically of palliative care, so I've skipped that one, but these were kind of like the 4 or so that I thought were pretty important. So yeah, emergency on the ward, what do we do? So the first big and probably like most distressing, at least to the staff, is hemorrhage. So you can just get basic kind of capillary bleeding where you've got obviously like a lot of these patients, they might have underlying end organ failure that's causing, like if it's liver failure, like obviously like loss of the clotting factors. They could have problems with vessel walls, some kind of cancer that's causing DIC, for instance, whatever the reason. Bleeding quite common. So if it's just that they've got a small capillary bleed, consider treating it with tranexamic acid. If it's like local to the skin, consider giving adrenaline or epinephrine to the affected area. Consider vitamin K as well if it's a problem with like clotting factor deficiency. There's then this pretty horrible thing called terminal hemorrhage, which for a lot of people it is a death event. It basically is where patients bleed out and die that way. They don't always die, which is a nice potential, but it's not supposedly meant to actually be that painful for the patients. It's more meant to be really, really distressing for the staff and anyone else, like particularly the families, to look and see. So it happens really rapidly. You get this massive blood loss in patients who you couldn't treat surgically. So you've got to treat it as a terminal event and then review 24 hours later if your patient is still alive. So make sure you give them reassurance, make the patient really aware that you're there. Excuse me, sorry. Yeah, make the patient really aware you're there. Move any family out if you can, because it's obviously like it's not really a great way for relatives to for relatives to see their a loved person to go. And in most rooms in hospices, maybe not so much hospitals, you should have these like dark blankets or dark hemorrhage kits, and they're dark for the reason of obviously like you don't want the blood to show up on them. It's like simply for that reason, just to reduce like the visual impact of it. Consider giving the patient midazolam and morphine just to like relax them a lot, kind of sedate them a little bit, because as much as I'm sitting here going, oh, I've heard it's not the most painful thing for patients in the world, because it is kind of like probably because they're just given the right kind of cocktail of things to make it comfortable. And again, if they're surviving after 24 hours, consider whether, okay, maybe this wasn't a terminal event. Do we need to give them an urgent blood transfusion and just like see how they're going on? Cool. So next one, hypercalcemia. So hypercalcemia itself isn't always a terminal event. There's a lot of different conditions that you can have it in. I've talked about it quite heavily when I did about myeloma the other week. But in about a small percentage of patients, it can be a terminal event. But about 10 to 20% of cancer patients can have it, and obviously you can have it in different conditions too. So always go for your adjusted calcium levels. So I wrote down what that was, if I can find it. So yeah, if you've got a patient whose calcium's fallen, adjusted calcium is between 2.2 to 2.6 moles per litre. So if it's going above that, don't go off like they're just their serum calcium. Then you're thinking, okay, this is hypercalcemia. And it, like, we talked about the symptoms of hypercalcemia last week. If you're struggling, it's the stones, moans, bones and groans thing. And I've included a good picture there that kind of shows you what it can cause. But generally in these patients, it's like, it's more the severe stuff. So like they're very comatose, they're very drowsy, abdominal pain, arrhythmias, etc. So you want to consider giving them fluid resuscitation and use bisphosphonates just to like drop that calcium level down. It's not generally like whereas terminal hemorrhage is quite a comparatively fast bleeding event. This is just one of those things. It's like, okay, if their calcium's up, and particularly as like cancer's in the underlying cause, it's a bad prognostic sign and they probably don't have long left, and it's going to have a lot of nasty side effects that may be the thing that kills them, the arrhythmia or something like that, for example, but it just might be another nasty side effect that we need to mitigate while this patient is unfortunately like in their last few days, weeks or whatever of life. Superior vena cava obstruction. This can happen, we talk about this quite a lot with particularly like thyroid or like upper tumours going on up here, and you get this characteristic, well, you get it with hypothyroidism as well, but in this instance probably not considered a terminal event. So here we're more thinking about, okay, we got a tumour that's causing some kind of compression or thrombus formation in the vena cava, or is there like direct invasion of a bronchial tumour or something, for instance. And you can kind of see in the patient, so this is the same patient in the picture, he's normal on the right, and in the left he's got this obvious facial plethora where he's like really puffy because he's not draining, or the vena cava is not draining everything here and up there as it should be. So they can be quite breathless, they can have neck vein distension, periorbital edema, so like swelling around the eyes, edema in like the neck and arms, and headaches as well. And the main way of treating it is just with dexamethasone. Consider chemotherapy and radiotherapy if it is due to a tumour, or consider stenting as well if it's a patient that you can manage in that way. And I think the last one, malignant spinal cord compression. So this is another particularly nasty one, but you can get this, again, like a lot of patients tend to get this in more than one spinal level. And it's just when a tumour has invaded the spinal column or like say the area around it. Usually happens in the thoracic spine, then the lumbar if not there, then in the cervical spine if not in either of the most common two. And usually it presents with this like narrow band of pain. So say for instance if it's here, narrow band of pain that's worse on Valsalva, so it could be like when the patient's coughing and sneezing, things like that. Generally it's worse at night. So with these kind of bony pains, so to speak, when they're worse at night, I don't know how much teaching or reading you'll have done on bone tumours and stuff like that. That's quite another like heavy whole presentation topic in itself, but you tend to be like more worried and suspicious of those when they are presenting with night pain. Limb weakness, obviously, limb weakness, reduced mobility from like secondary nerve compression, or sensory disturbance. And if you start getting sphincter disturbance as well, a little bit like with cauda equina, when you really worry about it when they get the sphincter disturbance, same thing here really. Actually, yeah, so cauda equina could be one of the presentations of this, depending on like the level of spine it's affecting. But if they're getting that, then that's like, okay, this is pretty big now, like we're potentially not going to be able to mitigate this surgically and with steroids. So investigate it, same as you would cauda equina if you've revised that already. MRI of the spine is your main go-to. Management, dexamethasone to reduce swelling, neurosurgical decompression if you can, radiotherapy again to target the tumour. But again, all these are terminal events, so unfortunately in a lot of these patients you get to a point where a lot of this just, you're going to sort of stop it getting worse. Sorry, that's my dog. You're going to stop it getting worse, but it's not going to it's not going to stop fully. Cool. So that is whistle stop tour of palliative care. I'm going to repost the Survey Monkey again. So again, I really appreciate your feedback. I apologise a bit if I do kind of rush through things. I'm just trying to get through stuff without it being like overly long for you guys. Anyone's got questions or recommendations of what you'd like? Because I think I am now with you in Wednesdays for like the rest of lockdown. So yeah, thank you for listening, guys.